Good evening and welcome to this session, this particular conversation from the Health from the Heart series of AMMA Healthcare Research Gurukul in collaboration with the Preventive Radiology Initiative of the Indian Radiological and Imaging Association. And in this particular conversation, we are going to focus on a new epidemic that is running through our country and in most regions across the world, something that is not come up so much into a limelight, that is coming up into the realm of recognition now. What is often called as fatty liver or fat in the liver, and it can be of two types, an alcoholic type or a non-alcoholic type. And the non-alcoholic fatty liver disease has got a very high magnitude right now, and it's increasing. To discuss on NAFLD and its progression and the identification of NAFLD and the strategies that the Indian Radiological and Imaging Association, through its Preventive Radiology Initiative, is planning to address, to tackle this particular epidemic, we have two eminent panelists with us. One is Dr. Chaubal, young, dynamic, the face of the young radiologists of India, one of the faces of the young radiologists of India, who is the director of the Thane Ultrasound Center at Mumbai and is a consultant at Jaslok Hospital and Research Center at Mumbai. He has authored many publications, has co-authored many chapters in textbooks, has got a passion for ultrasound, interventional ultrasound, ultrasound elastography, contrast ultrasound, and musculoskeletal ultrasound. It's also the Associate Secretary of the Musculoskeletal Ultrasound Society of India. Our other panelist is a familiar face, young as well, I better say that, young as well, Dr. Rijo Mathew Choorakuttil, who is the National Coordinator for the Preventive Radiology Initiative of the Indian Radiological and Imaging Association. And Dr. Rijo Mathew Choorakuttil has also been the founder member of the Samdakshan Initiative of IRIA that has achieved great milestones in the field of perinatal radiology in India. He has got a passion for fetal radiology, he's got a passion for sharing his experiences and building sustainable models that can improve radiological services in India. So, when we speak of fatty liver, a question that most often comes to many people's minds is that a problem in India? Is that really a problem in India? Is that something that we must look at? And to set the background for why we have this initiative, why we have this focus on fatty liver, it's good to have an idea of the numbers that are there. And several studies, population-based and hospital-based studies from India, have shown that 1 in 5 to as many as 1 in 3 people in India have some signs of fat in the liver. It can be an early stage, it can be a late stage. And it's a progressive condition, possibly can be resolved, can regress if we identify it early through simple modifications. But the numbers are high, 1 in 5 to 1 in 3. And a study from Thiruvananthapuram in Kerala reported, population-based study, a cohort study, longitudinal follow-up and all, reported 49% of adult population had some signs of fat in the liver. So it's a large number that's affected. Associate risk factors for this particular condition include hypertension, and we have a large number of people who are hypertensive or have increased blood pressure in India. Diabetes mellitus. Nearly 70 million people have diabetes mellitus in India, and the number is expected to increase to 123 million in the next couple of decades by 2040, by 2050. It's expected to increase, and all of this play a role in fatty liver of the disease. Obesity. We have seen an increase in the obese population in India. The National Family Health Survey 4 reported 18% of obesity among adult males, close to 20% in females. So it's again 1 in 5. So all these conditions predisposed to a high magnitude of non-alcoholic fatty liver disease in India. Additionally, what we have seen is that insulin resistance plays a role. And in India, we have a high association or a high prevalence of people with insulin resistance. So these factors play a role in the magnitude of NAFLD or non-alcoholic fatty liver disease in India. Now, another sort of myth is that liver diseases are usually associated with consumption of alcohol only, and it does not occur in people who do not consume alcohol unless it's an infectious event. NAFLD can occur even in people who don't consume alcohol to a large extent and is therefore a grave concern. Now, my first question is to Dr. Rajas. What's the role of imaging? What's the role of ultrasound in the early identification of fatty liver or fatty liver disease?
So yeah, as you rightly pointed out, Dr. Praveen, we have increasingly seen these fatty livers, over a period of time. So what typically happens is, these patients come to us either for some other problem, right? And coming back to your question first, sorry. When we talk of ultrasound, ultrasound as a modality is very, very important because, a lot of diseases, a lot of patients will undergo ultrasound for some reason or the other, right? And invariably when we are doing these ultrasounds for say some other problem or some other complaints, we end up detecting these fatty livers. So majority of the fatty livers that we really detect right now are incidental, or the other spectrum that we are looking at is this health checkup, right? We have a good number of patients who come in for a routine health checkup with absolutely fine parameters, and they undergo just a routine ultrasound, and what we see is fatty liver on ultrasound. So ultrasound really, if you look at it as an imaging modality, plays a terrific role in this early detection, because majority of these patients, like I said, will not even present with some complaints or some raised renal liver function test or any other abnormality, and they just happen to be seen on ultrasound, and we happen to detect the fatty livers. And as you rightly pointed out, the numbers are really alarming. So if we go over our daily cases, we are seeing increasingly an alarming amount of fatty livers. And it is not only the adult population, it is unfortunately seen in the younger population as well, which is actually even more alarming because these can worsen at a later stage. So yes, imaging definitely plays a very, very important role in these early detections. And um, and see, what happens is, all this while we didn't really have a way to quantify or see how much is the grade of fatty infiltration. So what all this while what we relied upon was just our visual interpretation. So depending on the visuals, we used to say mild, moderate, severe. There was no actual quantification for it. But now with these newer technologies which have come up, we are talking about fat quantifications in the liver. We are talking about these hepatorenal indices. Whole lot of things. We are actually able to quantify, how much is the intensity or how much is the grading of a fatty liver. And this again plays a very important role. Number one is why? Because it's a very easy test to perform. You don't really have to prick the patient. You don't have to put him through any other scanner. You don't need to perform any complicated maneuvers. It's probably just a 2 minute procedure, and we can actually give a lot more information about the fatty infiltration, which is the amount of fatty infiltration. So this is about a fatty infiltration, and when these patients progress, right, they progress into something called as liver fibrosis or eventually cirrhosis, which is a worst case progression. We are able to detect these cases also, as they are progressing into fibrosis. So imaging not only plays an important factor in detecting, but also monitoring these patients, how they are progressing. So if they are doing any, dietary changes, lifestyle changes, we can actually see this reversal of these fatty livers. We are actually seeing reversal of early fibrosis. So all this is possible. So it is very important to counsel these patients, tell them about it when you see this. And we have, like I've seen, like I said, we have seen a good number of reversals. So yeah, it's imaging, definitely ultrasound imaging is going to play a huge important role. Or it already does, and going ahead in the future, it's going to be even more relevant.
So the key aspects that are coming up is that imaging is painless, relatively painless, easy to perform, and it's
Absolutely
easily
painless,
available.
I would.
Yeah, and it's easily available, and you need to take an additional maybe 2 minutes, 3 minutes to do a good quantification study of the liver to get a basic idea. An additional, how would you consider imaging in the context of biochemical tests? A lot of biochemical tests are done for several parameters associated with an AFLD or with the liver. How would you place imaging in the context of that? Does imaging provide you with a better advantage there? Does it supplement and complement it? Or does it really give you a much greater advantage compared to those biochemical tests?
Yeah. So number one thing is, see, none of these, everything in medicine goes hand in hand. So it's not really one is more important than the others. But yes, there are certain advantages when it comes to imaging. Number one, like I said, majority of these cases are incidentally detected. So they would not have undergone some kind of a biochemical markers, some kind of liver function test to really analyze anything which is wrong in the liver, because it wouldn't have been even suspected at any point of time. Number one, right? Second thing is, some of these changes can actually be detected prior to these abnormalities coming within the liver function test or the biochemical markers. So yes, it does play a very important role, and but majority of the times it is concurrent with the imaging. So I mean, with the biochemical markers. So we always advise them to do a biochemical markers. It always adds a whole lot of advantage. We can see which phase, whether this is a compensated advanced liver disease, or whether it's decompensated. So it always goes hand in hand and gives you a much better information. But to put it in a nutshell, there are times where we are able to detect these changes even before they pop up in your biochemical markers.
So imaging gives you the advantage that it can pick up findings even when there are no particular symptoms as part of a test that is being done for something else, and it helps you to identify that. It also gives you an advantage that the biochemical markers may not be specifically targeting only a fatty liver condition. It can be many other conditions also contributing to that. But while the imaging gives you a picture of what is happening in the liver, and if you want to get into a more in-depth assessment of what's happening in the liver, you can go for a histopathology or a biopsy for that one. But the imaging gives you the first set. What sort of imaging tests can be done to for an AFLD or for fatty liver using ultrasound?
Right. So number one thing is what we call as the B mode assessment, right? Which is the basic ultrasound image, right? So typically when we look at the livers on ultrasound, we look at their echo texture, we compare it to the echo texture of the kidney, and this gives us our first hint at whether this liver is potentially fatty or not. Right. That is when we first start suspecting it. If the liver echo texture is brighter than the kidney. So that's where we start doing it. Now, the new things which have come up is something called as the hepatorenal index, right? So, what the disadvantage of B mode is that, or B mode assessment of the fatty liver, is that it is very operator dependent, right? So, for I may think as say something like a mild fatty liver, Dr. Rijo may consider it as a moderate. You may have some other opinion on it. So the problem becomes the inter-observer variability, and also these images will slightly vary depending upon the setting of the machine you are using. These factors pop in. So now we have a much better ways of analyzing things. If we have some semi-quantitative and we have some quantitative measurements that we can do. So one of them is what is called as the hepatorenal index, where we actually put this, what I'm talking in terms of the brightness, or terms of the increased echo texture of the liver. We actually put it in numbers, right? So we actually number how much is, or we actually look at the brightness of the liver, compare it to the brightness of the kidney, and we get a figure to this. So if this is, typically more than 1.2, 1.3, we can say that yes, this is fatty liver, and we can potentially grade it. So there still is a lot of research going on this. There is still a lot of publications that we need to really say which is mild, moderate, severe. But we have started getting numbers. The other thing is actual quantification of fat, which can be done in a couple of ways, and the most common way of doing it is attenuation of the ultrasound beam in the fat. So what happens is whenever there is increase in fatty deposition of the liver, the ultrasound beam goes on attenuating. So now this attenuation can be measured with particular numbers, right? So it is typically measured in centimeters per megahertz, and we are able to get a quantification value. So again, similar to the HRI, we can, or hepatic renal index, we can potentially say that whether this is mild, moderate, or severe, right? So once we start getting cutoffs of say about 0.665, 0.67, somewhere in that ballpark, we know that yes, this is a fatty liver. And what we have seen is that when we think on BMO that yeah, this liver tends to be a little more higher grade of fatty infiltration, we are getting higher values. We are getting values up to 0.8, zero point 0.9 also, right? So yes, this is a very good way of quantification or quantifying how much is the fat in the liver. So these
So,
are basically things which are available.
so leading on from there, who would you advise must be screened? Who would you advise must be screened for a fatty liver as a routine or as a targeted screening?
Okay. So majority, we are seeing more of these cases in the middle-aged, I would say men as well as women who are increasingly presenting with lifestyle disorders, right? Obesity, you're looking at hypertension, you're looking at diabetes, all these factors which are popping up, right? So yes, these patients do need to be screened. These need to be a part of your regular health checkup packages which are there, right? And like I said, unfortunately, this subset of patients is also there in the pediatric age group. So when we have metabolic syndromes presenting in early childhood, these also need to be screened. These are also good subset of patients to be screened.
So, coming to you, Dr. Rijo, why has the IRIA, the Indian Radiological and Imaging Association, started an initiative on preventive radiology? And why is NAFLD taken up as one of the priority areas for this preventive radiology initiative?
Thank you, Dr. Praveen and Dr. Regis Chaubal for joining in. Dr. Regis is the National Academic Lead for the NAFLD division of Preventive Radiology Program of IRIA. Indian Radiological and Imaging Association has taken several initiatives in the last 4 to 5 years, including the Samrakshan project that was launched in 2019 during the presidency of Dr. Hemant Patel. In last year, during the presidency of Dr. Amarnath Chelladuri, this project was suggested, and he was very keen on launching this project last year. And the concept behind it is in the whole realm of preventive medicine, radiology has got a very, very significant role to play, which has often been not highlighted or often been not explored. The thing is, uh, radiologists have always been known as diagnostic radiologists or a interventional radiologist. But in the diagnostic radiology itself, there is a larger space where radiology has not explored within the context of preventive medicine, where a symptomatic patient coming to you for imaging, we are going for differential diagnosis with different features, etc. That was one of the strongest areas in which all the competitive skills that the radiologists are trained with. Intervention is, of course, another area that we are trained with. But in the preventive medicine, there is a possibility that it's an asymptomatic patient who is at risk, and how can we stratify that risk with the help of imaging biomarkers? Because imaging offers a lot of biomarkers which are not, which of course we see many of them during our diagnostic workup for a symptomatic patient, but we do not give them enough importance to them. And for example, if you take the fatty liver itself, radiologist has been seeing fatty liver for the last 25, 30 years. Even I remember in 20 years ago, or 20, 22, 24 years ago, when I started my practice here in Kochi, Most of my reports, one of my reports which had fatty liver or fatty or increased echogenicity in liver and pancreas, for the first 10 years, most of the physicians, most of the even the gastroenterologists ignored it. They said, "Oh, that report will have radiologists will say that." That was the kind of attitude. Don't they just reassured the patient? Don't worry, you just leave it. But now, within this 5 to 10 years, I can see a significant change in their attitude, that they have realized that this is a problem that has got a larger magnitude, because the Trivandrum study itself was an eye opener. 1 out of 2 adult patients has got fatty liver means, and imagine the volume of people who can go in for a fibrosis and a cirrhosis and later require transplants. And now in in places like Kochi itself, we have realized that 20% of the liver transplants are due to non-alcoholic fatty liver disease. So the magnitude is such a high one. This is a real big epidemic that is unfolding here. So we have to take some measures at this point of time. Skill enhance the radiologists, who are the category of medical professionals who sees them on a regular basis, who sees them first in an asymptomatic patient as part of a executive checkup or health checkup or whatever it is. Patient has come for some other purpose, but we see it, and we have to now quantify that fact, because Regis was saying that there is a difficulty in quantification just by eyeballing to say that mild, moderate, and severe, but there has to be some semi-quantitative and quantitative parameters, because grade 1 fatty liver is if the fat increase, if the echogenicity is more than that of the renal cortex. So now we have got a hepatorenal index, as Dr. Regis has mentioned, which will give you some values for comparison. And it's not just the fat alone is the problem. Some of them, a large percentage, 4 to 5% of them may progress to different levels of fibrosis, and later on leading to cirrhosis and require all the complications, require liver transplants. So this is a huge problem. And if you take India as a whole, 1.4 billion population in the different stages of epidemiological transition. So as a developing nation, many parts of our country are in different stages of epidemiological transition. What do I mean by that is, some stages are still in the stages of famine and pestilence, where the issues related to communicable diseases, issues related to perinatal morbidity, maternal morbidity, all these things are very high there. But there is other part of country where it has moved to a different transition in the epidemiology. What has happened there is an increased incidence of non-communicable diseases, obesity, diabetes, hypertension. So cardiovascular disease. If you assess the mortality due to communicable diseases and non-communicable diseases, the mortality due to cardiovascular diseases are increased especially in the southern region of the country, western zone region of the country, and we are seeing it in many states in the northern parts also. So, and even in the urban area, city metros and mini metros, we see this trend. So there is a whole fatty liver is essentially a part of a non-communicable disease pattern that is prevalent in many parts of India, and the magnitude is quite high. So the preventive radiology program was intended to look into the imaging biomarkers and to do the risk stratification on a community level, irrespective of the healthcare we practice. So it is possible with radiologists. That's entirely new area that is opening up for radiologists. Radiologists has got a potential to have a radiology OP and to present themselves as primary physicians, because a symptomatic patient is not coming to you. You are reaching out, you are seeing an asymptomatic patient as part of a risk stratification strategy with the help of imaging biomarkers, and also you are adding other biochemical markers as well as other investigations, and then now bringing their risk into focus for a modification for the lifestyle modification or some treatment modalities being added into that. So this is a whole new area that IRIA thought about, that we have to explore. We have to skill enhance our radiologists at a very early stage, because this unless and until when it reaches the last stages of this thing after 20 years or 30 years, when we there is no point in enhancing the skills at that point. By that time, this is more of a intervention, more of a surgical problem. So right now there is a window of opportunity for preventive radiologists, clinical and preventive radiologists to act with the help of imaging biomarkers and do the risk stratification for the society, and counsel them with the help of other practitioners, other stakeholders in medicine. For example, in this particular case of fatty liver, we have the gastroenterologists, physicians there. We can they can advise the patients to modify their lifestyle, or even nutritionists and lifestyle coaches. All people can have a significant role, and also some drugs also are available right now to treat and these conditions. So the whole lot of possibilities open up right from the imaging stratification of the high risk group with the help of imaging biomarkers. So that is where radiologists are going to play a significant role in the diagnosis of fatty liver, especially the non-alcoholic fatty liver. I think there is entity is now developing into it is strong correlation with metabolic syndrome. So it's a metabolic disease dysfunction associated fatty liver disease. So that is an area that has to be explored, and radiologist has to play a significant role. That is the conviction behind with which we have entered into this project. And thanks to the support given by the National IRA leadership, Dr. Pushparaj Batele, Dr. Sandeep Kautale, and Dr. Amarnath Chelladure, the national team is wholly supporting this project. And this project is taking some new dimensions with young national academic leaders like Dr. Rajesh Chaubal, who has taken great lead in giving skill enhancement programs for the radiologists.
Now, this brings us to an interesting area. Now, we have about 17,000 to 18,000 radiologists in India. And how does the Preventive Radiology Committee visualize going through the process of skill enhancement for the radiology community in India? That's one question. The second question is an interesting point that you mentioned, and I would like you to highlight more on that. The preventive or the radiology OPD concept by itself, where the radiologist turns into a primary physician who can then triage into multiple specialties as necessary, rather than being just an image reader who reports back based on what is asked of them. So these two aspects, if you could shed some light, it would be interesting, Dr. Rijo.
Yeah. See how we are going to execute this project. This has got, as I mentioned, this has got multiple dimensions. One, as I said, the first is this is part. We need a awareness campaign amongst the radiologists and the other stakeholders, and amongst the general public also about this. So social media awareness, social awareness campaign is first part of it. And the second part of it is a skill enhancement program for the radiologists. For the skill enhancement program, we'll have an online and an offline component. Online component will be covering basically the modules that help us to do give you the aspects on the clinical aspects, the biochemical aspects, and also some of the technical aspects that we need for while we do the imaging test, and also the comparative. It's not just ultrasound alone as a imaging modality to look for the fatty liver. There are other modalities, other imaging modalities too, like CT, MR elastography, and maybe it's still the gold standard is considered as the biopsy. So wherever we are having a patient who undergoes biopsy, we can have a comparative effectiveness, a comparative evaluation of the diagnostic effectiveness of these modalities, and that has been studied throughout the world for the last 10 to 15 years too. So apart from the skill enhancement component of online and offline modes, the third component that we are interested to work out is the research component. Especially, we honestly believe that the research and the data that is collected from India and analysis of that data is going to be going to make a lot of difference throughout our study, and and also help us to formulate the strategies that is needed for India. So that I'm a strong believer of that, because 1.4 billion population should know what is happening to them, rather than depending on the data coming from a much smaller population coming from a Western continent, telling you the guidelines, which is not may not be much practically applicable, or many may not be much relevant. So we need to have a data. That is why the research participation. We are doing a multicentric research on non-alcoholic fatty liver disease with the comparative evaluation of the diagnostic effectiveness of uh, fibroscan, or the vibration controlled transient elastography. That is the modality that is commonly used by the gastroenterologist, though it is a lesser sensitive and lesser specific one when compared to the 2D shear wave elastography that is part of the radiology equipment, ultrasound equipment currently being used. And then there is MR elastography, which is again a specific modality but has got a little more costly, and then biopsy. So these four modalities will be compared in a diagnostic effectiveness, the multicentric study as part of this project. So, and fourthly, we wish to have some policy document from the association level at state and national level, to be submitted to the health authorities for to have these kind of programs integrated as part of the community screening programs, like just like the mammography screening program they have in the West. It is time for India to, as we are becoming a developing nation, it is time for us to think about this kind of a preventive screening protocols, preventive screening tests on a regular basis, to pick up to those high risk groups, and to apply and to give more attention to that high risk group, so that an effective outcomes are possible, especially in terms of the statistics that we have in India. That is a strategy that we all also recommended for the Samrakshan project also. So now, broadly, this committee wishes to have the awareness programs, the offline and online skill enhancement programs, including the workshops at various states in India, for which I feel industry also is very keenly supporting this preventive radiology program. Mindrec has come forward for the multicentric study, which is also because that again gives helps us to focus on the Indian data that is coming in. So multicentric studies with 10 centers all over India will be participating in this IRIA Preventive Radiology multicentric study on NAFLD. Fourthly, as I said, a policy documentation for the health ministry and the political and the bureaucratic bureaucrats to understand, to formulate further strategies on that. So we should not. We have to. We have to make them aware that if you don't address it at this stage, after 20 years, you will see an enormous numbers of liver transplants happening all over the country, which is something that may not be manageable at that point of time, and which will be costing the exchequer in a big way. So these are, if you can bud it, if you can address it at the budding stage itself, address it at the early stages right now, there is an immense possibility that nation will benefit out of it. A lot of unnecessary deaths can be avoided. A lot of unnecessary complications can be avoided. There is a huge lot of possibility existing there. So these are the four areas, that four points that we are planning to work out. But first and foremost is, apart from the awareness campaign, and as part of it, we are doing this I'm sure, Dr. Praveen, this will be released on Wednesday, if I'm right, 13th on YouTube. Yeah, right. Then skill enhancement programs, the workshops, we want to focus on trainer of trainer programs first. We are looking at those who can give skill enhancement at a workshop level, can give mentoring with as part of this program. And we are effectively, in fact, looking for 2 trainers from each state to join that program, so that If a program is planned, if a workshop is planned at that state, one or two national faculty may come, but two or three people will be from that particular state itself to take forward that skill enhancement program. And eventually, over the next years, those state faculties from the state, they can increase, they can their numbers can go up, and they will be able to provide skill enhancement for the next generation or the next group of radiologists who wants to join this program. So this is a broad perspective we have on this program, and I hopefully we will be able to do that.
So the skill enhancement program is planned to be rolling out, or it's envisaged as being rolling out in different states, initially focusing on a trainer of trainer component, and then through a hands-on as well as online and offline modules that cover different states. Now, Dr. Rajas, what are your thoughts on the challenges in upscaling the diagnosis of NAFLD? The challenges in upscaling that, especially in standardizing, the difficulties in standardizing, and sort of blocks or these things that might occur while we try to standardize processes.
Yeah. Standardization is definitely a huge challenge. So, what I would like to say over here is, we have been using liver elastography, okay, which is like a predecessor to this technology, for say over the last 7 8 years, right, or a little more maybe. And this what this helped in doing is, detecting fibrosis in the liver, right? So we used to say whether there's a mild, moderate, severe fibrosis, we try to pick up the fibrosis early and, nip it at that stage, reverse it at whatever stage. So now what we are trying to detect is, this patients, we are trying to detect them prior to they going into mild fibrosis. So when we did, start working with this fibrosis estimation component, we had a lot of challenges. Okay, to begin with, the problem is standardizing the numbers, right? So it's very difficult to come and say at one point, yes, 1.2 is the absolute cutoff. Even 1.19 is normal, but 1.21 is abnormal. It doesn't work that way. So yes, putting things into clinical perspective is very important. Like Dr. Rijo very rightly pointed out, we are right now relying on foreign data, which is probably not a huge subset. So we don't know how it really works very well in our context. And another thing which we have seen is, India again is a huge nation with a lot of variability in the population, with varying diets, all kind of factors which are there. So even that cutoffs may be different for different regions. So what is maybe very valid in north may not be as valid in south or east or west or whatever. But it's honestly going to be only that that data collection which will really help us to point in that direction. What we should be using as absolute cutoffs, where we are heading. From that perspective. So yes, I think that is a big challenge. Also at this time, the challenge is that these things are not yet available on all systems. In terms of all vendors are not able to provide it, all systems are not able to provide it. But this is something which will gradually be offset over the next couple of years, as the radiologists, as they go on upgrading the equipment, majority of the newer equipments will have these systems built into them. We already have started seeing what started off, initially all these systems were only available with the top end packages, the top end range of the of a particular model of a company. But now they have already started putting it into their lower and the more cheaper and the more affordable models. So as this progresses over a period of years, the availability of these systems will be huge all over the country, which is definitely going to help us in a lot of perspectives. And at this time, the other problem which remains is that there's a little bit of machine variability, inter vendor variability on the cutoffs. What somebody say X company is using as a cutoff, the Y company may be having different cutoffs, Z company will be having cutoffs. So, what I do see is with more amount of data being collected not only from India but also from abroad, these things will eventually go on standardizing. And once we have these more standardizations in our systems, into our reporting systems, interpretation of this, training radiologists, making them interpret it, conveying these reports if required to the gastroenterologist or the hepatologist or the physician or whoever, becomes much easier, right? So yes, everything is going to be a huge learning curve for all of us. And like Dr. Rijo pointed out, the data collection again from all over the country will really um, help us going forward. And the other thing I would like to point out is, we are trying to do these studies where we are trying to correlate our ultrasound findings with the MR findings. But it is not always, very easy to get this done. So there will be a lot of challenges, especially in the beginning, to set up these studies. Because everyone will be working with different vendors, so we don't know what kind of standardizations we are using. But I think it's only when we get a huge amount of data that we'll be actually able to put it together and say, what makes sense out of this and what doesn't.
Praveen, let me add on to what Regis has said here. I can see a certain kind of issues that currently exist in the uh, assessment of fatty liver disease and the quantification of fibrosis. Ultimately, that these are the two things that we have to focus for the from the patient perspective, from the national epidemic that we have that is unfolding. These are the two things: whether this patient has got fatty liver, whether this patient is in any stages of fibrosis. If so, of course, the risk stratification, as part of risk stratification, they go into a higher risk. This is the ideal this thing. But unfortunately, when it comes to practice, there are several bias or several. One is related to the modality bias, the kind of equipments that are used, whether it is ultrasound is good, whether it is the fibroscan is good, whether it is elastography is good, whether it's biopsy, whether it is CT. So it's a basically a professional. This another thing is whether this is, and that has been added by disciplines of medicine also. Different specialists see it in a different way. Gastroenterologist has got a bias towards fibroscan, so they feel that by fibroscan is more widely available and used by them. So they feel that fibroscan gives a, but literature that has come out very clearly says that 2D shear wave has got a superiority over fibroscan in this, in terms of sensitivity as in specificity. But there is again a certain kind of disconnect between the interpretations by different disciplines of medicine. So that's another challenge. So modality bias, the discipline wise, there is a no standardization. And again, when it comes to vendor wise, there is no uniformity right now, but there are lots of efforts that are coming in. But because sometimes if you say a particular value, that value may not be the from the standardized normal range of the other vendor. So when a patient who has done it in the equipment that with one vendor, and then comes for a serial follow up with another equipment, then there can be some confusions that can crop up, and that interpretations can have a little bit of difficulty there, especially in those who are in the mild to moderate ranges of fatty liver or in the fibrosis. Those in the extremes, either no or severe, hasn't got much of problem, but large chunk of our population is going to be in this range. So these are the three major biases I can see, major issues or major challenges that need some kind of a standardization. But again, let us focus as medical professionals, irrespective of the branch that we are, let us focus on only two things: whether this patient is at risk for a fibrosis, and how much of a quantification, whether it's a severe one or a moderate one that needs treatment. Then again, how this is, we have to see it from the perspective of national epidemic that is unfolding. So it is high time for us to come together, put our minds together, and act on it at this time. This is the ideal window at which period at which we can make a difference. 20 years down the line, we already missed that.
So I see, adding on to what you said, Dr. Rijo, I see two things coming up. One is that, as you rightly pointed out, the people at the two extremes, the ones who do not have now, and the ones who have got a severe condition that needs clear cut interventions to do something about it. There are clear cut pathways on both sides. The vast majority lie in the middle. And in the middle, you have conditions that you might pick up. And as you pick up, then the question is, are they truly having this particular condition? Will they progress, or who can progress, or who will progress, and who can regress and become better? Who will become better? And there are several factors at play there. Like Dr. Raja said earlier, you have the whole issue of lifestyle diseases there. You have hypertension, you have diabetes, you have obesity, you have environmental factors, nutrition, all these factors at play there. So, is it possible to identify who can improve or who can get back to a near normal state of their liver? And one advantage that the imaging offers you is a benchmark that can be visualized over a period of time. So once you have seen it at baseline and you have a visualization possible, you're able to compare against that particular visualization and see whether it's improving or it's not improving. Which brings us to the next issue, as you rightly pointed out, assessing the diagnostic effectiveness of the different equipment and the different cutoffs and the need for data from India. Much of the data is coming from a population that is Caucasian, primarily Caucasian. Most studies are from Caucasian populations, maybe a few from China and other Asian populations, but most are from the Caucasian population. When we say that we have a high incidence of metabolic syndrome in India, we have a high incidence of diabetes in India, we have a genetic predisposition to some of this, we have a gene environmental interaction for this, where they both interact and the risk becomes higher, then it naturally follows that it must hold true even for a condition like NAFLD, where the underlying risk factors may be different from that of a Caucasian population. And if we see the diabetes profile, we find that even if it's the body mass index, 23.1 is our cutoff as opposed to 25 for overweight and obese. For us, it is 23.1. So at a lower body mass index, our incremental risk starts increasing. And it must be similar for NAFLD as well. We see that with insulin resistance, where for a particular cutoff of insulin resistance, our risk is different from that of the Caucasian population. We are seeing that even with the histopathology studies that are coming. So the evidence is overwhelmingly in favor that there is a certain set of characteristics that lead to a different picture in our population. Identifying those characteristics with the ability to longitudinally follow them up, serially follow them up, see what's happening, helps to optimize the management patterns within this particular country. So your initiative of combining skill enhancement, training with data collection, relevant data collection, checking to see what is working, developing cutoffs that are relevant for our population, assessing and evaluating to see if those cutoffs hold good. How are they different from the Caucasian population data that we are having, or population data from other regions that we are having? It's a lot of work, but it's a good pathway to really optimize the whole process, because the key challenge is how do you minimize as much as possible the number of people that might require a liver transplant later. And if you are able to catch them early, arrest or get the process of the disease moving backwards rather than progressing into a more severe form, it eases the strain on the entire healthcare infrastructure. So what are any concluding thoughts or remarks from both of you?
Regis?
Yeah. So you can go ahead first. No,
Yeah.
so basically, I think we are definitely heading in the right direction, and I think from a more technical, I will just summarize the technical perspective. Ultrasound definitely will play a very important role in the future. I mean, in the near future, I'm talking about in identifying these patients and assessing how they are doing. Prognosticating them. See, whatever the changes they're doing is working for them or not working for them. And of course we do have challenges in terms of setting the the cutoffs right, and getting all these vendors on a single page, so that we are looking at more specific cutoffs, or more some cutoffs which are very close to each other, which has happened with fibrosis. So I'm sure if it has happened with fibrosis, it will definitely happen with the fat quantification techniques as well. And with this, we will have a much better ways to lay our points out, convey to not only the patient. I mean, because conveying to the patient is very important. Because we will be acting like a primary counselors. When we see these patients, because like we said, majority of these are going to be incidentally detected. So counseling them at that point, spending those just couple of minutes with them will be very important. Make them understand, and of course simultaneously talking to the physicians, the gastroenterologists, and the entire medical fraternity. So once we have these cutoffs in mind, with us, we will be able to talk in a much better, in a much more scientific pattern. So yeah, and we will definitely, I think, achieve this over the next few years.
Um, See, Praveen, we have got an ambitious plan to execute this project, with which has got multiple dimensions, as as I already mentioned, the awareness creation, then the skill enhancement component, the multicentric research component, the policy documentation. So all these things require a good team. So the team build up is the essential part of it right now. And uh, to be frank, I'm quite optimistic about, so far there are lots and lots of people from different parts of this country. Different radiologists from different states have expressed keen interest to take forward this project and to join this project either as a part of as part of a researcher, or a part of a trainer. I get a lot of as part of state IRA officers, office bearers who wants to conduct the program. So I'm getting a very in hopeful. I'm quite hopeful and optimistic about the way this project is going to take shape. Dr. Rajesh Chaubal is taking the national academic lead, but we have got more people who are already working on this liver elastography, especially with 2D shear wave. Dr. Anirudh Kulkarni from Aurangabad, Dr. Nandakumar from Bangalore, Dr. Manoj KS from Trivandrum, Dr. Amarnath Chelladure and his team from Stanley Medical College, Chennai. Uh, uh, there are and my own teachers, Dr. Nitin Chaubal sir and Dr. Chandralula sir from Jaslok. So there a lot of people of a lot of teachers and practitioners have expressed their interest to be part of this project, and also to be in the training pool or the speaker pool or the researcher pool. And essentially, I feel this is a kind of program that we are uh, building up to create clinician scientists, where the definitely the multi research component is actually giving an opportunity to not only enhance your skills and apply it to the patient population you have, but also in the data collection and the data analysis and the research involvement in research participation within the multicentric research participation organized by a professional association. I think this is evolving into a real good project, and I can see a lot of good things happening. And as Paulo Coelho said, when we have the desire, passion to do that, the universe conspires to help us do that. So that is really happening. I can see help, support, and a lot of blessings and guidance coming from different parts of the country. Different state IRAs are wholeheartedly cooperating with the project. Different institution, different senior radiologists, and different young radiologists too, who feel some kind of a resonance to the whole project of preventive radiology. They feel that this is the right time for radiologists to because if you look at the even in the NEET entrance or the All India entrance exam for the last 30 years, radiologist has been the radiology was the most sought after branch. And what is their contribution to the social this thing apart from their professional excellence? So this is time for radiologists to prove to the country that they can do something for the nation too.
So,
Praveen, I think I've gone too far. But we're quite
Very
hopeful
well
of
said, sir.
bringing our young fraternity into the forefront as part of this project.
so there are two key takeaways that are coming up as a summary. One, for the radiology fraternity in India, this is a project that aims to involve every radiologist in India, and it aims to work through the state chapters, state associations to provide training to upskill yourselves with a focus on a condition that's going to become an epidemic, that's already an epidemic, and it's going to gain more prominence in the near future. So it's something that helps you to plan for your future, plan for a future workload in a more systematic, organized manner. It involves not just training and then leaving you alone. It also involves training, post-training mentoring, post-training looking at your data and trying to tell you where you need to improve yourself, what is happening with your data, what's happening in your region, and then walking you through the whole process. And building a whole set of trainers within each state who are capable of taking this up on a large scale within that particular state. So if you are a radiologist, I would strongly recommend that you get in touch with Dr. Rijo Mathew or Dr. Rajas and see how you can involve yourself further with this particular project. And through the state IRA that's going to come through, the information is going to come percolating through, and you will be getting the chances to participate in this particular program. If you are a patient, or if you're a person who has been diagnosed with NAFLD, the good news for you is that there is now going to be a systematic approach towards trying to find out the ways for early identification of fat infiltration in the liver using a painless minimal contact method. And the reporting doesn't take a couple of days or weeks to come through. The reporting is fast. The procedure is painless. The procedure is easily done, widely available. There's a large number of radiologists in the country. You don't have to rely on certain labs in certain situations alone, in certain cities alone. It's widely available. And so it can be done in most parts of India without any hassle. And this information will help to develop management protocols that are of particular relevance to the Indian population. And so we would be able to more clearly streamline who is more at risk to progress and needs more intense follow-up, who is likely to resolve or become better, and what are the strategies that can be applied for both these groups. So there is an element that's helpful for the patients as well. And this is also a project, even though it's not coming out very explicitly, this is a project that has got a community element in that the impact of the whole program and the screening on the community is something that's going to be assessed through the data collection that comes from each trained radiologist. And so we'll be able to say that it meets the three aims, if we can call it the three aims of a healthcare intervention. One is the quality of the healthcare intervention. Two is the impact on the community, and that it reduces or it minimizes the particular magnitude of that condition or the consequences of that condition in the community. If that intervention doesn't do that, then that intervention is questionable. And the cost element. So it's not going to be a technology that is very costly, so it cannot be available for most of the people. Ultrasound is not too costly, it is available. People can afford to do it, and it's widely available. So it also involves a cost. So it's looking at all these things in a more holistic manner. We will continue these conversations with Dr. Rajas and Dr. Rijo Mathew Choorakuttil, and we will see how the program is progressing, and we'll have continuous updates both for radiologists as well as for the general public on how this is progressing and what stages are we in and what is happening, so that the awareness increases, participation from both groups, the radiologist group and the public and the community as well, their involvement with the program also increases. So thank you, Dr. Rajas, for taking your time. Dr. Rajas, one of the
Thank,
young
thank you.
new
Sorry.
leadership phases of radiology in India. Possibly we can say with confidence, one of the phases of the future of radiology in India. He's blushing. And Dr. Rijo Mathew Choorakuttil, for whom age is just a number. He's young. He's young, he's passionate.
Completely.
Young, passionate, and waits in with full dedication into every project that he takes up. And so the Preventive Radiology Initiative has been handed over to someone with a track record of proven commitment and outcomes. So thanks to both of you for taking the time to be here and sharing your experiences.
Thank you so much for having me here. Thanks a lot. Thanks a lot.
You're welcome, and we will be getting you back here, so don't think you have escaped.
Definitely. We'll be more than happy to be back here.
Thank you, Dr. Praveen, for initiating this discussion on preventive radiology and fatty liver disease. But this is a very important subject that needs several deliberations, and I think, as I've already explained, that we have got a large, ambitious plan to execute here. And as a chief research mentor for this project, I again wholeheartedly request your help and support and guidance for the research element of this particular project. Thank you, Dr. Praveen.
Okay, so till we meet again, stay safe, be happy, keep smiling, and make sure that your livers don't have so much fat in them. Thank you so much.
Thank you.